This motion picture clinic is the first attempt of its kind to present for the use of physicians only a clinic covering the diagnosis, treatment, and general care of a disease. Dr. John H. Stokes, professor of dermatology and syphilology in the University of Pennsylvania School of Medicine, presents the diagnosis of early syphilis.
The diagnosis of early syphilis, primary and secondary, is a laboratory problem. The physician in practice must therefore suspect, examine closely and completely, collect diagnostic material, collect it again and again. If he cannot do so, call an expert who can. Follow tenaciously and relentlessly through time and with the aid of contact tracing and serologic follow-up each case to a definite conclusion. The old-time clinical criteria for differentiation of early syphilis are unsound diagnostically in primary syphilis, intricate and puzzling in secondary syphilis, procrastinating and dangerous in both. A chancre may occur anywhere except on the teeth and nails. It may be too small to be visible to the patient, so large as to deceive the physician. It may not develop at all. It may be superposed on any open wound or sore, does not require a previous abrasion, may be out of sight in urethra or on cervix, may be masked by the discharge of a gonorrhea or produce its own urethral discharge. Histories of exposure and calculated incubation periods are unreliable. Do not expect to see typical lesions. Regard all genital lesions with some suspicion, and in all lesions, genital or extragenital. Look for, but do not overweigh, the three great suspicion-arousing features of indolence, induration, firm or cartilaginous field, satellite adenopathy, the local lymph node enlargement, bilateral on the genitalia, unilateral elsewhere, discrete, usually not tender. Though an untreated lesion is desirable, it is not indispensable. Salt solution soaking for 24 hours, aspiration of an indurated base, suction after vigorous rubbing or scraping, aspiration of adjacent lymph nodes, repeated collection of material on successive days may yield a positive dark field. The inexperienced physician is not encouraged to use the dark field microscope. The direct dark field examination from the fresh specimen is, however, the ideal when performed by the experienced or expert. The essential requirements for satisfactory material intended for dark field examination for Spirochaeta pallida are lymph or blood serum, not blood. From the deeper parts of the lesion, clean and abrade the surface gently but with determination. Collect in a capillary tube with or without the aid of a suction bulb. The ends of the tube then sealed by thrusting into sterile petrolatum. The blank form filled out. And the capillary tube then returned to the container, which is sealed and sent at once. Request report by phone or wire if positive. In his eagerness to prove a case, let no physician be betrayed into doing either a provocative procedure or a therapeutic test in a doubtful situation. If the patient will not wait, he should agree to go ahead under such circumstances with a full year or more of standard treatment for syphilis, regardless of the test result. If the first dark field fails or is negative, repeat at 1 or 2 day intervals, using salt solution wet dressings or soaks between times. Persistence over a week, if possible, is essential. Examination of women patients for primary syphilis is rarely adequate. Lesions on the external genitalia are inconspicuous and symptomless. About 60% of chancres of the genitalia in women occur on the cervix and require a dark field on a specimen obtained with a long capillary pipette on speculum exposure of the cervix. The clinical appearances, ranging from a vesicle to a pseudocarcinoma, are totally deceiving. Make speculum examination of all exposed women. Most syphilis in women is not diagnosed until secondaries appear, and often not then, since the tendency is towards constitutional rather than eruptive manifestations, and indurative lesions, with associated regional lymphadenopathy. Why is a physician's own primary infection so rarely diagnosed before secondaries appear? Not because he has no chancre, though this may occur in needle prick inoculations, but because he has a low index of suspicion for the disease. Either he never suspects at all, or he gets panic and makes diagnosis impossible by premature treatment. He rarely turns to the dark field, seldom to the blood test until too late. If the dark field is reported repeatedly negative, and the blood likewise is syphilis excluded, not within the first 3 months. Serologic follow-up, a blood test every week after the 3rd week, monthly after the 2nd month, dating from the time the lesion was first seen, is as necessary in the diagnosis of early syphilis as the initial dark field. Early syphilis develops slowly, often inconspicuously, must be followed along with tests. Serologic follow-up for syphilis should be performed in all cases of gonorrhea and in many nonspecific urethridities developing after sexual exposure. Piecemeal and incomplete examination defeats many diagnoses of early syphilis. Strip every patient at the first visit and examine the skin and mucosa as well as the suspected chancre or the part complained of. Secondaries may be found to prove a primary or a primary to prove up secondaries. Some lesions that look like chancres are merely relapses in older infections. The ensemble of the case may determine the diagnosis and treatment as much as the blood test alone. The diagnosis of secondary syphilis today rests on the fact that a competent laboratory gives little short of 100% positive ossamin and precipitation tests on florid secondary syphilis. A repeatedly negative blood test practically excludes secondary syphilis. The problem is, therefore, to get suspicion aroused to the point of an adequate examination, then to take a blood test, and lastly, to avoid the gross occasional mistake of calling a non-syphilitic eruption syphilitic. The constitutional symptoms of early syphilis are seldom specific enough to arouse suspicion. Suspicion should therefore attain the automatic status of a blood test for the disease on every new patient. Chronic headache, chronic sore throat, bone pains and localized tenderness, persistent anemia and weight loss in young women would achieve new significance. A general lymph node enlargement or a palpable spleen may be a diagnostic landmark. Relapses and recurrences of early syphilis are common under insufficient treatment with the arsenicals and mercury by mouth. The mucosal and genital relapses are gravely infectious, inconspicuous, evanescent, numerically important. Examine the mouth and genitalia where most of them occur. Have dark fields, for these patients may be seronegative. Suspect moist spots, moist papules, fissures, split papules. Suspect piles. Suspect all rings, especially about the genitalia. All groups of darkish, firm, or fleshy papules, and take blood tests. If you will undress patients, use good light and sharp eyes, and suspect, eternally suspect, with the laboratory at your elbow, you will rarely miss early syphilis, but a moment's loss of vigilance may let it pass. This demonstrates a simple method of examining the anogenital region in women for infectious lesions, which can be used in ordinary office practice. Secondary syphilis is usually hard, not easy to see. Use good light. Expect faint macules and papules, groups of follicular lesions, rather than pustules, rings, and sores. A fleshy field of papules is suspicious. Patchy hair and eyebrows warrant Wassermann. Peer into the corners. Stick your tongue out. Put it over to the right. Over to the left. Out of your mouth. Way out. Draw it back. Say ah, 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 ah. So, close your mouth. The anus and genitalia. Drop your trousers to your knees. Please.